Hi, everybody. Welcome. My name is Nicole Lamberson. I trained as a physician assistant, and I volunteer doing outreach for the film Medicating Normal, and I host conversations like this one today. I'm excited today to welcome our guest, Dr. Igor Galynker. He's the founder and director of the Mount Sinai Suicide Prevention Research Laboratory and of the Galynker Family Center for Bipolar Disorder. He is director of research at the Mount Sinai Beth Israel Department of Psychiatry and professor of psychiatry at the Mount Sinai School of Medicine in New York City. He's written 4 books and co-authored over 250 publications and presentations. His most recent book is this one, the second edition of the Suicidal Crisis, and it is on the recommended resource list of the American Foundation for Suicide Prevention. He is a nationally and internationally recognized expert in suicide research and prevention, and he maintains an active research program in suicidology that is funded by the NIMH and AFSP. His research focuses on identifying and treating the suicide crisis syndrome. So welcome, Dr. Galynker. Thank you so much for joining us today.
Thank you for having me. It's a pleasure.
Yeah, sure. So I guess I just want to start out with, a brief sort of summary from you about why suicide, why the interest in studying suicide. It's such a stigmatized topic and depressing. So what made you interested in it?
There were 2 reasons. Now that I've been doing it for 15 years, I can safely say there were 2 reasons. There was a conscious reason and unconscious reason. So I'll tell you the conscious reason first. About 2008, I believe, then the medical director of American Foundation for Suicide Prevention, Paul Clayton, came to our department to give a talk about suicide prevention, suicidology. And it was a wonderful talk where there was a lot of biochemistry, serotonin, impulsivity, and wonderful research, except nothing was said in that talk about what actually happens in somebody's mind before they kill themselves. And so at the end of the talk, I asked the question, actually, do you know? Do you actually know when you see somebody who you've been treating for a while and who may or may not have been suicidal, when you see them for the last time, and what's happening in their mind? And she said, no. And I asked, is there a framework for that? Is there an understanding? And the answer was no. And that was one of rare moments when you realize something almost startling. We have the most lethal psychiatric condition, which is suicide, or suicidal mental state, should I say. And that psychiatric condition is present in depression, schizophrenia, panic disorder without any other disorder. And we don't have a description of it. We don't know what the symptom is, what the syndrome is, how it develops, how to treat it. And there's a giant gap, in psychiatry, undescribed. And it must be described because people die from suicide and suicide rates are going up. So that was my conscious reason, and it was at the time. And that was enough that I stopped doing the research and the work that I was doing at that time, which was family treatment for bipolar disorder, and started my research career in suicidology and suicide prevention, basically from zero, from scratch, describing the syndrome. And the subconscious reason was that when I was when I was a young attending in my first year at Beth Israel, I started treating a patient who had a terrible life story, meaning that he had a partner who he lived with for 25 years, and then the partner died. And it turned out that the partner had a double life and had another family, and all that was happening as the patient, my patient, had no idea that that was going on until the wife showed up at the funeral. And then a year later, he did kill himself while in my care, while telling me that he was never suicidal and denying it until the last moment. And then after he died, I got a letter from him telling me that, God, you did, Doc, you did everything that you could, and I'm sorry that I lied to you. Okay. And so that informed the decision that was present from the very beginning. And it is that we will not, in our research, we will not rely on suicidal ideation. Okay, because suicidal ideation is inherently, at that time we didn't know how actually it worked, but inherently unreliable because people are not going to tell you. They're not going to tell you when they're suicidal. And now we know very well why they would not, and what is the reason behind it, and who they would talk to and who they would not talk to. But the asking people about suicide, if you think about it, okay, as a mainstay of your diagnostic risk assessment and suicide prevention is misguided, to say the least. Because let's say this is a rhetorical, dramatic question, but an important one. Would you ever, as a clinician, ask a patient with schizophrenia to diagnose their own schizophrenia? The answer is no. Would you ever ask somebody who has bipolar disorder to diagnose their own bipolar disorder? And the answer is no. Nevertheless, we're asking a person whose mental state is more serious and more lethal than both of the above, and yet we rely on their judgment to tell us how suicidal they are and what are they will and will not do. Okay, and that's actually, frankly, absurd. So that's the long story.
Okay. You've sort of led me to another question, but I'll get to it later with that. I just want to talk about your book quickly. Sure. Who did you write it for? I mean, who is the intended audience and how do you want it to be used?
This is the second edition of the book, and it says a clinician's guide for preventing suicide risk. It is primarily for clinicians. Okay. I mean, this book of all clinicians. However, it also can be used by lay people to learn about the suicide crisis syndrome and suicide prevention, the whole model of how to track suicidal process in somebody, process mind, and what to do about it. And there's 60 case vignettes in that book, I believe, that describe various stages of the process and what happens in people's minds. And obviously, it is not a very cheerful read, but it's an important one for those who, for some reason, are interested in the topic. It's this book is 400 pages, or close to 500, I don't remember, I think. The first edition of the book was 250 pages and had a lot less science in it, because at that time, everything that we talked about was still a hypothesis, and since then it was proven as fact. So, but the first book is more easier read for people who, for lay people.
Okay, great. So let's dive in and talk about suicide. I mean, are we having a suicide health crisis in America? Yes or no?
Yes.
Okay.
No question about it.
Okay. And then the next question that people are going to definitely want to know is why? Why are suicides on the rise, and in what specific populations, if we can sort of narrow it down?
Well, let me describe the populations first.
Okay.
And the rise, and then we'll talk about why.
Okay.
Because the description is easier. So the suicide rates in the United States rose steadily since about year 2000. Okay, 1999, I think, to 2000. So that has been 23 years. They rose by 3 to 4% per year 2% per year in the first 10 years, then 3 to 4% per year afterwards. Until 2018, when they peaked. And then there were 2 years of pandemic when they went down, in my opinion, predictably, because in the times of crisis, our fight or flight responses and survival instincts kick in. We want to survive. And that's what happened during COVID. But when COVID ended, the suicide rates started climbing up again at 5% a year. And the latest numbers that just came out last week of 2022 is 49,499 people. So next question is who? Okay, who? And as probably everybody knows, or most people know, suicide more frequent and more prevalent in men than in women by a factor of 3. Okay, 3 to 4. The suicide rates went up in younger people, actually, remarkably so. And 2017 was a remarkable year because in that year alone, suicide rate went up by 10% in 10 to 24-year-olds and by 50% in 10 to 14-year-olds. It was children's suicide when the phenomenon appeared. And suicide rates were rising faster in women than in men, and in girls than in boys. The latest statistic is somewhat different, and to me a little bit surprising, in that the rise in suicide from 21 to 22 was 8% in people over 64, 6% of people over 44, more or less flat or 1% in people from 24 to 44, and 8% drop in people who are younger than 24, which was unexpected. Still, the rise in suicides was higher and faster in women than men. So that's what's happening in terms of statistics, and also in blacks, in African Americans, the rise is much steeper.
Okay.
It has been. Traditionally, it was much lower, and the Black women were at the lowest risk of any group for suicide, but the rates have been climbing, particularly in Black adolescents. So then, next question is why? There's many associations. The most obvious one is the rise in social media, screen time, and technology in the last 20 years. From the point, and this is what I guess the critical watershed, in my opinion, is that in year 2000, it was possible to live without mandatory use of computers in every possible action that you take. And now it has become close to impossible. Okay, in fact, use of computers, even in mundane tasks, even if that computers make it more difficult, which is often the case as opposed to easy, we're forced into using the computers and screen time. And also, this is a known fact, is that screen time, every possible aspect of screen time increases suicide risk and is harmful for your mental health. Meaning any screen time daily, on top of that, any screen time of your smartphone, on top of that, any screen time on social media, and on top of that, cyberbullying. In every of these 4 steps, suicide risk increases. And in every step of the way, it increases higher in girls and women than in boys.
So we should not have our children on social media.
You should not have our children in social media, which is, it's a sidebar on discussion of technology and what it does to actually humankind as species, and what it has been doing and will do, which is not good, to put it mildly. But that's probably not what we're focusing on right now. But technology is not good.
Yeah. I mean, I'm even thinking of like, okay, when you were younger and we didn't have all of this technology, you could break up with somebody and it goes away. You have to grieve and all of that. But now you can look at them forever and see what they're doing and who they're dating and all of that. I imagine that makes it harder for people.
Absolutely.
Yeah.
Absolutely. It makes it harder, specifically. So since you brought up the breakup, the risk factors for suicide, there are several stressful life events that may lead to suicide. Final romantic rejection is one of those factors, could be the most frequent ones. It's associated with suicide within 24, 48 hours. The best, there's no good breakups, but the least painful ones, when you remove triggers from your environment, everything that you had together, the photographs of it, so you can start anew, you're not triggered, and you cannot do this anymore.
Yeah. Okay.
It's very much harder to do it, let's put it this way.
Yeah. So in the book, you talk about some topics that I think are important for people to understand. There's imminent suicide risk versus long-term suicide risk, and then the suicide crisis syndrome. Can you tell people what those are so that we understand?
It turns out, that lifetime or chronic suicide risk is actually quite different from imminent risk. And what we typically think of risk factors for suicide, such as depression, for instance, or pessimism or impulsivity or all the things that we think about, or mental illness, is actually chronic risk factor. They don't increase your suicide risk for tomorrow. Okay. So depressive factors and everything that we typically think about is that increase your, risk like lifelong, 10 years from now, 20 years from now. The imminent risk is much closer, the mental state of imminent risk and the suicide crisis syndrome is actually much closer to anxiety and panic than it is to depression.
Okay.
And it is short-lived state that lasts probably days, hours, days, sometimes minutes, but typically hours. And it is very well described. And when a person in this state, they may kill themselves. And the imminent risk factors are anxiety, panic, insomnia, social withdrawal, inability to think clearly, some increase in alcohol abuse, which is not something that you would think about. Ability to think rationally, for instance, is a problem. Inability. So the suicide crisis syndrome, since you asked, is the name that we gave to the suicidal mental state, which is really mental state that requires diagnosis as clearly diagnostically as, let's say, panic attack or depressive episode or psychosis. It has clear criteria. You can diagnose it by asking questions. It has it has neurobiology that needs to be investigated, and it should be treated with medications. And if you treat suicide crisis syndrome with medications, regardless of whether somebody does or does not have suicidal ideation, because suicidal ideation is not part of the syndrome for the reason that I described before. It's a footnote to the syndrome. If you treat the syndrome, that will prevent suicide.
Okay. So I guess that's kind of a good bridge into, that our film is called Medicating Normal, and we talk about the risks and harms of prescribed psychiatric medications. So maybe let's talk about, what is the industry standard for treating suicidal people? You say they need medication, but is that like they need to be put on chronic long-term antidepressants, or what is the treatment in your experience?
the issue and the treatment, the problem, the treatment is based on Diagnostic and Statistical Manual,
Okay.
which is the Bible of mental disorders.
Mhm.
And in the Diagnostic and Statistical Manual, suicide is not present. A suicidal mental state is not even there.
Mhm.
What is there only is suicidal ideation, which is present in other conditions such as depression, unipolar and bipolar, and borderline personality disorder and substance abuse, hypothetically. So there is no method by DSM, by current thinking, to treat suicidal crisis. There's no method. So instead of that, the recommendation is to treat what is called underlying disorder, okay, which will be either depression or psychosis or something else. There are people who have no psychiatric diagnosis who kill themselves.
Mhm.
I mean, without ever being depressed, by the way.
Yeah.
The people who kill themselves without ever being chronically, consciously suicidal. And so what happens when somebody comes in with what let's call suicidal thoughts, suicidal ideation, they get they treat it for underlying disorder, which would be, let's say, depression. Okay, they put an antidepressant. Antidepressant, when you start somebody on antidepressant, in many cases, initially causes increased anxiety, sometimes severe anxiety. The suicide crisis syndrome is an anxiety and panic state. So if somebody has it in a kind of mild form or partial diagnosis, actually starting antidepressant can increase the intensity of it and actually can result in increased suicide risk.
Mhm.
And although there was no studies like this, I would put my money that the reason suicide antidepressants are associated with increased suicidal thoughts and suicide risk is because they intensify subclinical suicide crisis syndrome that's already present by increasing the anxiety.
Mhm.
So this is one side of the story. The other side of the story is that when you stop antidepressants, okay, and many other medications, now I'm not going to be talking antidepressants, when you stop antidepressants, when you stop antipsychotics quite often, when you stop benzodiazepines, when you stop any sedating drug, and stop them abruptly, the result is a dramatic increase in anxiety or appearance of anxiety that was not there, or appearance of panic that was not there. And of course, again, if they have subclinical suicide crisis syndrome, that's just going to amplify it.
Mhm.
And what I see in emergency rooms all the time is that people come in who are suicidal after suicide attempts, and 2 weeks ago, they stopped a medication. They stopped SSRI or stopped something, and immediately withdrawal started, which can be severe, and withdrawal has all these symptoms of anxiety that I described to you could have associated with increased suicide crisis syndrome intensity.
Yeah. So I guess I'm just misunderstanding a little bit though. Is medication, say you're having adverse effects to medication that are making you anxious or actually causing suicidal feelings in someone, or they're in severe withdrawal from a medication, how does that relate to suicide crisis syndrome? Do you have to have, I mean, when you're getting withdrawal, does that sort of push you into being diagnosed with suicide crisis syndrome, or?
When symptoms of, let's say, SSRI withdrawal,
Mhm.
okay, are very uncomfortable. Okay,
Oh, yeah.
they include headaches.
Mhm.
Okay, they include severe anxiety, they include insomnia, they have all kinds of somatic symptoms. All these symptoms are there. So headaches are part of the syndrome.
Mhm.
Okay, racing thoughts with headaches and pressure in your head are part of the syndrome. Insomnia is part of the syndrome.
Okay.
Emotional turmoil is part of the syndrome. So you can even say that the abrupt antidepressant withdrawal would create the syndrome.
Okay.
Okay, but most likely and the most dangerously, somebody may have some of that already.
Mhm.
Okay, but it's only going to make it much worse.
Okay. I see. What do you think just in general about the current way which we as a society sort of treat suicidal patients, like, call the cops and then put them in a very, in my opinion, non-therapeutic environment, like a cold hospital room where, people are just sort of sat in front of a television and you're there for 3 days and sent home. I think there's even a study out there that says like people who are hospitalized in a psychiatric facility have an even greater risk of suicide when they get out. So
There is-
I'm wondering what you think about like our current model of doing that.
Well, let me, first of all, let me answer your, kind of clarify your last statement. There is more than one study.
Mhm.
There's actually three studies of a period of about 20-25 years.
Okay.
I think the earliest one is 2005, sorry, 20 years, that show that people who are being discharged from a psychiatric hospital in the first week from discharge,
Mhm.
in the most dangerous period of their lives for suicide, general.
Okay.
And the risk for suicide for those people, completed suicide, is 250, okay, to 1, okay, in
Yeah.
women and 100 to 1 in men, over those who were never admitted.
Wow.
Not over those same people who were admitted previously, but over those who were never admitted.
Okay.
So, which does tell you that psychiatric hospitalization does not do very much, at least. Okay,
Yeah.
it's not a panacea at all. The problem, I don't hospitalize suicidal patients,
Mhm.
like as a rule, and I
Okay.
have a lot of suicidal patients that I treat. I don't hospitalize them. The reason being is because it does not really treat the syndrome and does not often resolve stressful life events
Mhm.
that led to the syndrome, and the suicidal narrative, which is part of our model for comprehensive suicide prevention that I can actually talk to you about, which is in the process of evolution. So I think psychiatric hospitalization is essentially treating psychiatrists' legal exposure.
Mhm.
Okay, in my opinion, that's primarily the same thing, because when you don't know what to do, and the obviously preventable suicide, you break confidentiality, you hospitalize people, and then you're not liable.
Mhm. So
Okay.
you mean
Nothing happens.
CYA is what you're cover your ass is what it is yeah.
Kind of.
Okay.
It's essentially to treat the clinician and relieve clinicians' anxiety, and also there's clinicians have very negative response to psychiatric to suicidal patients. It's part of the book and the whole chapter about that.
Mhm.
What treating psychiatric patients does to clinician, what to do about that.
Mhm.
But it is really not helpful. I don't think there's any data to show that inpatient hospitalization is clearly helpful.
Okay.
So what do we need to do?
Mhm.
What do we need to do? How do we need to treat suicide or prevent suicide? And I'm going to be talking right now about the person, okay? Because there's certain things that can be done as a society. Let me actually mention those things. So the US is the only country in the world where majority of suicides are done by firearms.
Mhm.
By a mile. It's more than 50%. In other countries, it's 10%, 5%. So
Is that mostly in men or
not only men and women.
wow, okay. I had read something that like men are more likely to do more violent type
That's
deaths.
true.
Yeah. Okay.
That is true. And yet I'm sure I'm not sure, but I suspect that you read the report from 2 weeks ago of Mount Sinai doctor who shot her baby and then shot herself in a
Okay.
postpartum depression, most likely.
Mhm.
Okay, and it was a gun.
Mhm.
So this is means restriction, and I think also there are societal things we can do in terms of controlling social media, smartphone use, etc., to minimize the damage. Okay. And I think it needs to be legislated ASAP. Okay, so this is society.
Mhm.
On a clinical level, let me start kind of with the most important thing. When somebody has suicide crisis syndrome, then imminent danger.
Mhm.
Okay, whether they tell you that they're suicidal and whether they not tell you that they're suicidal. People talk about their suicide crisis syndrome and part of their suicidal narrative. You can recognize it.
Mhm.
Okay. If somebody is in that state, and they're telling you, and I can go with the syndrome in some detail, if they tell you that they find themselves in an unbearable situation with no exit and they can't think and they can't sleep and they're in terrible pain, okay, that means something. That's the syndrome that needs to be treated immediately.
Mhm.
And when people are in that state, in extreme state like this, they cannot hear you. Okay, they're in acute pain. It's like having a broken arm.
Mhm.
I just had a session with a patient actually before I went on. I started talking to you. She has a broken leg.
Mhm.
Okay, and she's a highly functional person who fell and broke the leg. And she said, without me prompting her, she said, having a pain is so distracting. I cannot do work and cannot think about anything except for pain.
Mhm.
When somebody is a mental pain of suicide crisis syndrome, they cannot hear you. They cannot think about anything. They cannot be rational. So the first thing you need to do is to treat that syndrome with medications. Okay, short term, I mean a day, 2 days, 3 days. Okay.
Can you expand a little on what kinds of medications
They're
typically?
suitable. They are medications that are available right now. There has not been clinical trials. We're trying to start one right now.
Okay.
It would be a combination of sedating antipsychotics, benzodiazepines, in the very severe cases, even pulse treatment with an opiate.
Okay.
Okay, like happens, for instance, when people have a heart attack, they're given morphine.
Mhm.
Okay, and nobody gets addicted to morphine, but it calms people down, and it's a vasodilator, so you improves blood to the heart. It's the same type of thing.
Okay.
It improves blood to the brain. Acutely treats the pain.
Okay.
So once the pain is treated, okay, then you can engage in treating the underlying causes, the mental processes, the entrapment, and everything else that brought people to suicide. And because they can't hear you that the final rejection, romantic rejection by one person is not the end of life.
Mhm.
It's one rejection, but there are other people. They can't hear you if they're in that syndrome. But after you treat it, they can.
Mhm.
And that's really important.
Yeah.
So, so how should we treat that? There are several stages to suicidal, to mental processes that make suicide possible. Okay. That is described in the book on the narrative crisis model of suicide.
Mhm.
And there is a chronic stage when people are not in acute risk. There is a subacute stage when people are in subacute risk. And then there's imminent risk and acute stage. So the chronic stage is when somebody is a perfectionist and fearless and pessimistic. These people, when stressful life events hit, they tend to see those stressful life events in catastrophic terms.
Mhm.
Okay. And see their life in catastrophic terms that we call suicidal narrative. So that long-term pattern, which is, let's say, the first stage, let's call it the first stage, can be treated long-term. And if people learn in psychotherapy, okay, to be less perfectionistic and accepting of life limitations and other people's limitations, suicide risk lowers.
Okay.
Then if we are in a stage when they're after a stressful life event, okay, they form what is called, we call suicidal narrative, which is a kind of a narrative view of themselves and their own life as a failing of the only goals that falling short, I'm sorry, of the only goals that would make them happy, the only ones, and in a catastrophic failure that is visible to everyone, is incredibly humiliating, that disconnects them from other people, and they see no future. Okay, so that's a subacute stage when people think like that, and that, okay, can be treated with some medication, some psychotherapy, because at this point you can actually, if there's no suicide crisis syndrome, you can actually talk to people, and people hear. Okay, so but that is crisis intervention and more intensive process. And when somebody develops the syndrome, when somebody in syndrome stage, that's medication, and then going back, okay, to the treating the suicidal narrative. That would be, in our opinion, is the best, would be the best approach. I think the approach of risk stratification that we have right now, meaning identifying people at high, low, and medium risk, is problematic. The problematic is that most people who kill themselves are judged to be at low risk. And there's a lot more of them than those at high risk. So judging people low risk, if they have the syndrome, for instance, just because they tell you they're not suicidal, okay, is it's a problem. It's problematic.
Yeah. Okay. In your book, there's a lot of risk factors for suicide, but I'm wondering if you think, well, first of all, if we are over relying on psychiatric medications as a society, and if so, if that's contributing to the suicide crisis. I mean, especially you talked about young people, and there's all kinds of studies. We know that SSRIs increase the risk of suicide attempts in young people. I mean, it's on the label. And then I think I've read too that there's other medications that can make people more suicidal. Even like statin drugs can have, adverse effects for suicide. So are we as clinicians sort of missing this piece that we're an over-medicated society, and maybe that's contributing to a rise in suicide?
I do think that we are over-medicated society. Okay. I did not look into this as a scientist, so I don't know the statistics. But there's one thing what I do know is that, for instance, ADHD is not considered a disorder in Europe. Considered developmental delay in Europe, and it's not being treated by stimulants. So the kids are not getting medicated, okay, at an early age. Which, by the way, let me give you a typical scenario that I see like on a daily basis, okay, for over medication, in my opinion, that may result in suicide, a suicide attempt in young people. So a typical scenario would be like this. There is a kid growing up, I mean, and a kid is imperfect, let's say, restless, or maybe inattentive. So the kid is being sent to a psychiatrist who diagnosed ADD. Okay, and put him on Adderall. Kid may have some, depressive problems, and Adderall may cause side effects. Okay, so something happens, and the kid is put on SSRI. Or more likely, let's say Adderall. The kid takes Adderall, but he's now 15 years old. He's applying for colleges, and he's still falling short of the Ivy League, that he's destined for, some other goal. Develops depression. Okay, or thinks that develop depression. So in addition to Adderall, he's put on, or she is put on SSRI. Graduates from college, goes to college, discovers that he or she, or they are not the brightest person in college. okay, because it happens all the time. College is more selective than in high school. On SSRI and Adderall, starts drinking, starts using weed on top of that.
Mhm.
So this or starts using more Adderall during the exams. So this typically snowballs. And if somebody has any vulnerability for bipolar disorder, okay, would develop a manic episode in the process.
Mhm.
And or would develop side effects from Adderall that results in crashes with depression. Okay, so one of the way of people getting on SSRIs is because Adderall causes crashes. People become depressed in the evenings and weekends and put on SSRIs to mitigate that.
Mhm.
They can develop, these people can develop mixed states, which is a combination of anxiety, agitation, and depression, psychosis. And in that state, they can develop suicide crisis syndrome and kill themselves.
Mhm.
That would be kind of almost chemically induced.
Yeah.
Suicidal behavior.
Okay. Yeah, because we know that alcohol abuse can lead people to suicide or other substance abuse. So I feel like sometimes we just sort of put things into categories like alcohol, cocaine, bad drugs, because our doctor prescribes Adderall, SSRIs, benzos, these fall under the good category. But I do know that the ones that are so-called in the good category prescribed by clinicians can cause suicide in folks. And maybe we're just not, as a society thinking about that risk.
So let's, what I described like 10 minutes ago, meaning the initial increase in anxiety and panic and suicide crisis syndrome, or increase in those same symptoms when somebody abruptly stops the drugs,
yes,
can be mitigated when you just do proper psychiatry and take care of people and call them on a regular basis and stay in touch when we start and stop medications.
Yeah.
Our family center, the way we work is everybody has my cell number or our cell numbers. When people start medications, they call me daily. You text me daily, and so this is not missed. And if we have adverse effects, we stop the medications. So that part of it does not necessarily can be dealt with. What you're concerned with and the medicating normal is concerned with is long-term treatment with psychotropic drugs for people who don't need those drugs.
Yeah. And withdrawal syndromes that are mismanaged. I mean, I've been in the online communities for psychiatric drug withdrawal for 13 years, and the suicides that I see are because, and my own, I had a suicide attempt from a severe, brutal benzodiazepine and polydrug withdrawal. And it's because people are suffering so much
Terrible.
from the withdrawal.
I'm sorry, second. I feel for you because I know what it feels like.
Yeah.
I've seen it. It's absolutely terrible. But the symptoms are so much worse than the initial symptoms that we're treated with. Okay, it's almost indescribable.
Yeah. But then also you go back to the prescriber or multiple prescribers looking for validation. And a lot of people are reporting that they're being told withdrawal doesn't exist, or it doesn't last that long, or, it's the return of your underlying condition. And so I think they just become so desperate with the fact that there's no acknowledgement or help as well, in addition to how badly they're suffering. And especially with benzodiazepines, because there's sort of this lack of understanding of the difference between physical dependence and addiction. And so a lot of benzo withdrawal patients who were compliant, once they get a severe withdrawal, they go back and they're told, well, you're a drug addict, and so we're not going to actually, give you more benzodiazepines to stop the suffering. So
it's absolutely terrible.
Yeah.
And I'm not the drug company's most favorite person, to put it mildly.
Yeah.
Okay, and the reason is because actually I had an opportunity to see the inside workings of some of the companies.
Mhm.
Okay, and I know what goes into, and the medical industrial complex is a huge money-making operation.
Yeah.
But I don't know if you know, but even if you do, or the listeners knows, is that CVS is the 10th largest company in the world,
Mhm.
and Walgreens is 12th. And these are the two companies that control all the drugs in the United States. Okay.
Yeah.
So, there is so much money involved into this, okay, in this that you may not necessarily get all the information to put it mildly.
Yeah.
And there were lawsuits that drug companies were hiding side effects like diabetogenic side effects and antipsychotics specifically. And I personally sent an email when I was 35 years ago, when I was a resident. I noticed that clozapine increases glucose in every single person that I gave clozapine to.
Mhm.
So, and I was, very young. I didn't know how the system worked. And instead of sending it to FDA, I actually sent it to Novartis and said, "Look, guys, that's what your drug is doing. You should take care of it." There was no response, and that was like 88. So I'm not surprised that the withdrawal symptoms are minimized. There are, however, they have articles appeared and proposed criteria for 3 kinds of antidepressant withdrawal specifically.
Mhm.
Okay, so one is recurrence of the initial symptom, meaning depression, 2, short-term withdrawal, and 3, long-term withdrawal. And
Mhm.
long-term withdrawal can last years.
Mhm.
Can last years, and it's in the press. It's been published.
Yeah. Okay. So you touching on the, sort of corruption and pharma industry. I wonder though, are you getting any pushback from mainstream for your defining suicidal crisis syndrome and treatment of, just short-term medication management, keeping people out of the hospital because it's contrary to what the DSM and people are following? What do your colleagues say?
Well, I don't know what I'm getting pushback. First of all, there's a lot of people who are very much in agreement with what I'm saying,
Mhm.
both in the US,
Okay.
okay, and abroad.
Mhm.
So we implemented our approaches, North Shore University Health System in Chicago. That's 8 hospitals. I
Okay.
got a grant from the AFSP to implement it across Mount Sinai Health System, which is the largest SIM system in New York. It's been implemented in Norway. I just gave educational courses. Just this year, I gave educational courses on our approach in Chile, Hungary, with Spain and Portugal coming up. It's being used in Italy, in Russia, and in other places. So it's kind of snowballing.
Okay.
There is a pushback, and you never know who is behind the pushback. That the syndrome, maybe it's not the syndrome. Maybe we just need to ask people questions, and in mental status exam, or we need more data. You never know who is behind all this.
Mhm.
And the most important thing must happen. Okay, and this is kind of our approach and strategy. We did a lot of research defining it. It's been defined. It's the same all over the world. We have
Mhm.
papers showing that it's the same syndrome. If it is in DSM, Diagnostic and Statistical Manual, either diagnosis or condition for further study, then everybody would be forced into knowing about it.
Mhm.
Okay, and that will change things.
Okay.
Because once you know how this syndrome works, okay, which by the way I have not described it in this podcast, but people who want to can look in the book. Once you know, you cannot. Once you learn, you cannot unlearn it.
Mhm.
You're not going to look at suicide prevention the same way.
Okay.
Because I just gave a lecture to first-year residents at Mount Sinai, and the response was, "Well, I have a patient who has it right now. What do I do?"
Yeah. Okay. Is there a lecture out there available to folks that we could post where if they like really want to dive in and learn all of the details of suicide crisis syndrome, or do they really need to just purchase the book and get into it?
Purchasing the book would help. The syndrome, the checklist for the syndrome is posted on our lab website, which is being updated.
Okay.
At the moment, it's Galynker Lab at Mount Sinai.
Okay.
And it's a checklist with all the symptoms. There are articles that have been published. I teach a course at the APA every year, okay, on preventing suicide in people at imminent risk who denied suicidal ideation, okay, and intent. So it is out there, but it is simple, okay. It is actually simple to diagnose it. Okay, if you know which questions to ask.
Okay. So maybe as we're coming to the end of our time here, something more practical for just lay people, I guess, who are, you know, concerned about someone, you know, I feel like the way we the messaging we have around suicide now is so cold and like non-human, and maybe that's part of the problem today is our society is sort of shifted towards that, where it's like, oh, call this 1-800 number, you know. What's better advice for lay people who are concerned that somebody is in the suicide crisis syndrome or at risk?
Get the family involved, okay, the loved one involved, the close one involved, and don't leave them alone. Okay, until they see mental health professional and the syndrome resolves. That's the general approach. And
I guess, are there better mental health professionals to bring them to, like someone who is trained and aware of the suicide crisis syndrome, as opposed to mainstream, like put you in a psychiatric hospital, you know?
More people know about it. So the question is, what is geographically? I mean, in New York, half of the people who come to the family center, I mean, have the syndrome or some of it, so we treat it. I know that Rochester and has a very established suicide prevention program, and they use it.
Okay.
So I don't know anybody in, let's say, in Louisiana, I mean, who uses it.
Yeah.
And you need unfortunately, you need to search. And so if anybody here kind of is listening who can help to get it into mainstream, okay, by let's say putting it on social media, I mean, including you, then that probably the best thing that can be done, or media of any sort.
Okay. So ultimately your goal really is to get this information out and to educate as many clinicians and hospitals
and lay people. So we have 4 minutes left. I don't know how much time we have left, but I want to tell you the syndrome.
Okay.
It's actually
if you can stay and you want to get into it a little, we can do that. Yeah.
Let me see what I have next in my calendar. 1 second.
Okay.
Okay. I can probably go 2-3 minutes extra.
Okay.
So the syndrome has 5 criteria: 1 criterion A and 4 criteria B.
Okay.
Criterion A is frantic hopelessness or entrapment, and it's trying to escape from unbearable life situation when all routes to escape are blocked.
Okay.
So that appears as the only option. And it can be anything. That can be romantic rejection, could be catastrophic financial failure, it can be something that's a threat to identity, it can be anything. Okay, it's only 7 or 8 ways of people experience it. So that's what brings them usually to the office. That's what they talk about spontaneously. If you listen, the feeling is that I'm in a situation, there's no solution. I'm trapped. I'm in a dead end. I cannot get out of it. I don't know what's happening. Nobody understands, and everybody's tired. So that's the first question. The second criterion is emotional pain or affective discontrol. And the way to ask about it is that what this problem that you have that sees no solution, how painful is to you? I mean, do you feel emotional pain? How bad is it?
Okay.
Okay. Or do you have like panic attack with strange sensations and that pain is that way? So that's criteria B1.
Okay.
The next criterion is criterion B2, which is loss of cognitive control. And the way to ask about it is that, you know, when you deal with this situation that you see no exit from, do you have control of those thoughts, of your thoughts when you think about it? Or you feel your thoughts are controlling you and it's out of control and you can't stop them? Okay. And do you have so many of them that your thoughts are racing and you feel pressure in your head or headache? Okay. This is criterion B2.
Okay.
And the last two questions is, and when that happens, when you know you're in pain and you can't stop thinking about this and situation that you have no exit from, can you sleep and does it happen at night?
Okay.
And so that's B3, which is over arousal, and B4 is social withdrawal. And the question is, have you told anybody about it? Does anybody know? Okay.
Do most people tell someone?
Most people, not everyone.
Okay.
But most people, if you listen to somebody, okay, talk, one of your friend, your loved one, and they're talking about your life, and you see this, you hear this. I keep thinking about it, I can't stop. I mean, I can't find a way out, and I keep thinking about it. Or it's just, and it's so terrible. I never felt like this before. Okay, or I can't sleep. I'm staying up all night. Do you have something for it? I mean, this is it. This is the syndrome.
Okay.
It is, and people may or may not tell you I want to kill myself. If they do, it doesn't make it any less intense. But if they don't, it's still an issue and it's still danger.
And do some people get through? I mean, I'm thinking of times where I've been in situations like that, or friends that I've known would check off all the boxes, but do some people like white knuckle it and survive?
Yes.
Yeah.
It's a short-lived syndrome.
Yeah.
It comes in waves. So if you live through those several hours, that's if you're not alone, if somebody is with you, okay, the intensity is going to lessen, either with medication or without.
Okay.
Okay, and so you'll be in between the waves, and you can do something. You can listen to somebody. You can, there's a most important psychotherapeutic treatment for this is opening doors out of the trap, finding ways to open doors when all the doors are locked.
Okay.
But
I like that.
you have to treat the syndrome okay, before people can hear you about this.
Right. Okay. So it's really the syndrome that's there's so much noise and everything in the mind and the racing thoughts that you can't even penetrate to let them know that there are doors that could open.
You got it.
Okay. So I guess in closing, if you had one big message that you want to make sure everybody understands about suicide before we go, what would you say?
What I said, it's preventable. It's an epidemic. It's a crisis. It's preventable. We're going at the wrong way. The suicide crisis symptom in the right way. You know now how to ask about it. It needs to be in DSM, so everybody knows about it, the whole world. It's going to change things. And we need to finish our research and get it there to get it in DSM.
Okay.
Okay, and we need money to finish this research.
Yeah, we always need money for research. So yeah. So we'll put links in the description and comments below for people to your book and the Suicide Prevention Research Lab. And if you want to support Dr. Galynker's research, we'll put a link for that as well. I guess in closing, thanks everybody for joining us for this live discussion. If you haven't seen our film, Medicating Normal, and you would like to, you can go to our website at medicatingnormal.com/watch. Thanks again, Dr. Galynker, for joining us, and everybody for watching. You're doing great work, and it was fascinating to have this discussion with you today. So thanks for making the time.
Thanks for having me.
Okay.
Happy to talk more.
Yeah, and here's his book, The Suicidal Crisis. We'll link to it if anybody wants to get a copy and learn more. So, all right. Take care. Okay. Bye-bye.